sector. So there's a huge power play which needs to actually be interrogated seriously so that adequate care can be taken in terms of financing the informal sector. Of course, again, there is the other issue is other issues revolve around working partnership. Working partnership, like Dr. Akpovera was saying, there was a situation where they formed associations and the government had to, probably fund such associations in order to be able to finance the informal health sector. But the truth is that if you go down and carry out a serious evaluation of how much the people bought into it or how much that program succeeded, you'll be shocked to find out that partnership was actually not workable. It was a partnership that was based on convenience and not a partnership for delivery of health services. So again, that also is another issue here. And of course, you have a host of regulatory agencies. And these agencies that are in the health sector, you find out that informal sector are excluded from membership in most cases. Who determines it? They are those in the formal sector.
Thank you,
participation.
Prof, you need to round up in the next 2 minutes.
Yes, I'm trying to round up now. It's almost I'm almost budgetary exclusion and of course competing institutional which create problems too for the informal sector. And theoretically, I think where a lot of these actions that go on in terms of financing the informal sector has to do with social class conflicts. The conflicts between the bureaucratic class, which has almost joined the bourgeois and the peasant class. So there's struggle for resources and there's inequalities in power, and these are causes. So thank you very much for listening.
Thank you very much, Prof. I hope you wait till the end because there's still some questions that we're going to ask you. This has been very, very insightful, very enlightening. I have made so many notes here.
The truth is that I have to stop over. You can hear vehicles flying the road. I was on my way traveling to Benin.
Well, there will be some questions I'm sure that you would need to answer. So maybe you just keep your lines open and we would need to continue. There are a few announcements that the Chief Engagement Officer would like to make. So Prof. Bangwell, we really, really appreciate your participation. And then we will appreciate that somebody's already raising their hand. Please, okay, let me take Shuaib. Please don't start your car yet. Shuaib Ahmed, before we recognize our dignitaries. Shuaib Ahmed, quickly, a very quick one. Shuaib Ahmed, mute your mic. Shuaib Ahmed.
Hello, everyone.
Yes, go ahead.
My own is just I want to make a comment concerning the political economy. I felt that the issue of political economy concerning healthcare financing in quite a number of provisions. For instance, the National Health Policy make adequate provision for relating to Abuja Declaration of the 15%. Earlier in the morning, something was mentioned about this.
Hello,
a lot of states.
Hello, Shaibu. We will give you the opportunity to do that. We'll give you the opportunity to do that in a few minutes. Please, I want to call the Chief Engagement Officer to recognize some personalities before we continue. Please, let's do that quickly. Then I would, give you the opportunity to make your, contribution on political economy. Thank you. So, Chief Engagement Officer, Dr. Hope Weja, please. Dr. Weja.
Thank you all. I think at this junction, I wanted to recognize some key personalities that had been brought to my notice, which present we really want to appreciate. One is my original Oga, Dr. Mohammed Lekki, who actually brought me from nowhere to the world of health financing, and I'm always very, very grateful to him. I want to recognize him for his outstanding contributions to what we know today about health insurance and all what was the foundation of what today we are celebrating or deliberating about. So, sir, I really want to welcome you. We really want to appreciate and thank you for your outstanding contributions to the provision of quality, affordable healthcare to the teeming population of Nigerians, and for your continued effort to making it a reality for those who don't have. We truly appreciate you. Secondly, we want to appreciate the advisor to the president on health, Dr. Sama Anas, who is ably represented here by Dr. Mohammed Suleiman Lawa. We want to thank you for your presence, your continued efforts, and your collaborative effort with the African Economic Forum and the Institute of Health Insurance and Managed Care. We thank you, ma'am, for your presence. We also want to use this opportunity to recognize Dr. Justin Okonobo, former Speaker, Edo State House of Assembly. It's on record that it was during your tenure that the law on health insurance was passed in Edo State. We really want to thank you for your vision, and we really want to thank you for all your efforts, continuing efforts to ensure that Edo State moves forward in relationship to having access to universal health coverage. We also want to thank you for all the collaborations you are holding currently with us. We want to appreciate you, and we thank you, sir. And we also wish you help us extend our greetings to Madam when you go back. Thanks. We also want to thank, of course, thank the state, the DGs and executive secretaries. But today, I really want to thank the executive secretary for my state, Delta State, Dr. Isaac Akpoveta, for all his efforts in driving health insurance and access in Delta State, and also Dr. Abiodun Oyeniyi, the one for Ondo State. We really want to appreciate you all. I must also recognize the development partners. I have with me here a very senior personality in the world of international development, the person of Dr. Ofuma Festus. He is the Chief Africa Officer for Options. And some months back, I recognized him as a regional director for Options, but today he's in charge of Africa. So, sir, I want to congratulate you for your achievement.
My brother, thank you.
And we look forward to continuing collaboration with you. I also want to recognize Dr. Onamani Dorti, the Managing Director of Novo Health Africa. She's my sister, actually. And in every collaboration we do, she always come in number one. We want to thank you, ma'am, for taking all the time from a very busy schedule to be with us today. And last but not the least, I'm sure we still
You're welcome. Thank you.
Mr. Ifeli Chukwu Innocent, the Advocacy Campaign and Policy Manager for Survive for Save the Children International. We really want to thank you, sir, for taking the time to be present here. We appreciate you, and we look forward to further collaborations. Back to you, Dr. Guinea. Thanks, and God bless.
Thank you very much, Dr. Weja. Shaibu Amodu, you had the floor, and then after Shaibu Amodu, we will take a question from Ibrahim Umar.
Okay. So, thank you, Chair. Like what I was saying, the comment I'm making concerning the political economy,
yes.
As far as this country is concerned, the National Health Financing Policy have adequately implemented Abuja Declaration. I am sure many of the states currently they are meeting, and some are even surpassing that Abuja Declaration. The only problem is when in the area of releases, and I think we also bring this to the public so that we can be able to see how do we improve in releasing the finances, to take care of the vulnerable. The other one is the National Health Act. Also, it adequately take care of the basic health care provision fund. Now the swap is trying to, look at modifying the system. I just a few days ago, the DG National Health Insurance Authority was mentioning that over 2 million people from the basic healthcare provision fund. You can see that we cannot be able to share out in this particular meeting without mentioning that in terms of commitment, in terms of political economy, there is a commitment from the government. But one other area that have been neglected, essentially speaking, you see, is the issue of reaching, tapping from the organized trade unions and some other in northwestern state. There is an organization, the Farmers Association. They have 1.5 million members in that state. Apart from there are many, many other. I felt that these are low-hanging fruits, which most of our contributing agencies are supposed to take advantage to fund the financing of the healthcare and then also expanding the informal sector. So I think this is my contribution, Mr. Chairman. Thank you very much.
Can I just add a point to the political economy situation?
Who is that?
At the end of his discussion,
yeah.
Our special guest speaker did mention that some of the activities in Delta may not be sustainable. Well, I don't know, but I would like to mention that we had what we call Artisan Enrollee Inducement Initiative. Artisan Enrollees Inducement Initiative. The purpose we want inducement there is because we know that when you give somebody a loan, he may have to sustain himself next time. But to do that, we ensure that they receive good care at the provider end, which is what I said earlier on, the advocacy to the provider end, the supply side is very key. When you induce somebody into a scheme by giving a small loan, and he enjoyed it, or his relative enjoyed it, definitely next year he will be able to respond himself and buy into the scheme. And so we cannot run away from the fact that some people will fall out of the program, but a lot of them will find the benefit of being an insured person and the advantage therein, and they will subsidize themselves and ensure that they keep on the scheme.
Thank you
so it is working. We have had renewal rate that is quite high over the years.
Thank you very
we are about
much.
9 years in the scheme now, so we can talk with statistics.
Thank you very much. Thank you very much for that clarification. Excuse me, because right now we have just 1 hour and 5 minutes to go, and we still have the second panel session, and we still have a presentation. As a result of this, I would crave our indulgence for us to go straight into the second panel discussion, because from it, we are going to get a lot of insight also, and I might address our questions and our concerns. So I would like to call on Juliet to introduce the members of the next panel session, which we are going to be having. Juliet, please, are you there? Juliet Ija.
Yes, thank you very much.
Please take the introduction of the people that will be participating in this panel.
Okay. First of all, I would like to thank Dr. Samuel for that insightful session and for our participants for engaging activity. For the second panel section, we will be having English guests in the form of Dr. Chief Africa Officer, Africa Division, Consultant. We will also be having Mr. Moses, who is the National Coordinator for the Insurance and Managed Care. We will also hear from Dr. Dorothy, who is the MD of Novo Health. Additionally, we'll be having our Haji From the Katsina State Free Health Commission. And finally, Abiodun Oyene, Director on the State Free Health Commission. Look forward to learning in this session. Thank you.
Thank you very much. I want to welcome the panelists to this session, and then to say that each of the panelists will have 5 minutes to discuss, and then make their insights known to us and share their experience with us, particularly as it relates to the political economy of financing the health coverage for the informal sector. I would like to start this by calling on Dr. Ufoma Omobi, the Chief Africa Officer, Africa Division, Officers Consultancy Services. You have the floor, ma. Dr. Ufoma.
So, good evening, everyone. So that you can know that I'm not man, I'm a mister. So this is me.
Okay,
so for those who don't know, Ufoma is a unisex name, and I think that would start my conversation. That there's a lot of echo coming through.
Yeah, I think Juliet, please, Juliet, work on your mic. Thank you.
Please, there may be need to mute everybody.
Now it is good. It's clear now. Let's go.
Great. Thank you very much. So, like I said earlier on, it's a good way to start the conversations when we come into the dialogue with a lot of unknowns. And I really want to commend all the speakers before me who have done a very good, dealt a very good conversation, or provided a lot of perspective as it has to do with the subject matter. What we are going to be looking at in my few minutes, next 4 minutes, 30 seconds, is how do we address the challenges for vulnerable populations within the informal sector? And the last speaker, I think it's Professor Madison, the gentleman that is on his way to Benin, really raised a lot of questions, that was quite interesting for me, which is who actually would need to pay for the poor and the vulnerable? Who will pay for those who are excluded? How can we aggregate the voice, and how can we engage, in such a manner that we can deliver quality healthcare for vulnerable population? How do we address financing? Because nobody, like you pointed, is really including the informal sector in the budget process. And that's a big question, right? This year's UHC Day had the theme, health is on government. So my question back to every one of us listening, and is the big question we need to ask a lot of our stakeholders within this country and within the continent, is when the word say health is on government, is it government for those who are maybe in some sort of health coverage scheme within the formal sector? What about the informal sector? It's a big question that I would love us to begin to ponder on. In the last couple of days since we had the UHC Day, there have been a lot of discussions. Government's agenda has been quite very clear. Our current NHIA DG has said that his plan is that Nigeria, gets to increase coverage. We've seen a lot of traction. We hear now that from 12 million, they are now covering about 19.2 million. It's also to raise the awareness as an agenda, as a priority agenda, around health insurance, and also build confidence and trust and promoting equity. And I want to bring out that equity piece, because that's where the issue is. How do we tackle, health poverty? Because the question is that who takes care of vulnerable, poor, excluded populations? People who maybe we have described the informal sector Dr. Madison described the informal sector, but there are people who are just excluded, not because of because of the challenge of their own. They're excluded because of poverty. Poverty. How do we tackle health poverty? You know, they can't even afford healthcare. They are either people living with disability. They're either people who are without jobs. We know the number of people in this republic who are without even any sort of jobs. So we can't even call them. Where do we class them in terms of whether they are informal or informal sector? Informal sector has been defined for artists who can as a bit of loan, like my big brother, Professor Dr. Boveta, mentioned in Delta.
You call them the poor of the poor.
Poorest of the poor.
Without any means of livelihood.
Exactly. How do we tackle those category of people? And what about those who are at risk of being, at risk of, financial, being exposed to more poverty because of medical emergencies, for no reasons of their own? For example, we had the issue of cholera, Lassa fever. How do we support those people? We know how COVID dealt with every one of us, and how we really need to begin to really talk about, really, like I love that theme of this year's UAC Day. Health is on government. Health is on government. There's no way, whether it's formal, informal sector, there must be a deliberate agenda to ensure that the current trust of government, which is increasing health insurance coverage, targeting vulnerable health populations, and quality of care and partnerships. And I think a lot of speakers spoke about it earlier on, how we need to strengthen the partnerships between the private sector and the public sector. And very importantly, the conversations around innovative financing, which we see examples have been given by Dr. Boveta, what is working in Delta State. The speaker that spoke here also talked about digital health. How do we use the digital economy to create options so that the burden to pay for health care become reduced to willingness? I was telling someone, do you know that when you use for support, you do pay for dancing, people talk about pulling people together, organizing cooperation and all of that. Those are approaches that people have said have worked. For us, what we have done, and I'll be speaking at as an example of our work at options and what we've seen work across geographies.
1 minute more.
This agenda needs to do with investment, and we know that there's call for. I know people have said yes. You'll be done with the 1%. The key is that give us more money first. It's on government, number one agenda. Then we need to look at BHCPF, right? How is it working? How are the gateways structured? I'm talking about at national level, and how is it working? We know there's an accountability mechanism, but how do we increase voice? Somebody talked about advocacy. How do we increase voice for civil society? And I just challenge us. Some of the things that will work, and we've seen it work, like in Jigawa, where we supported the civil society to talk about it. What government responded by putting 480 million as funds, and that covered about 40,000 vulnerable population. So it's possible. Then the other thing also that someone raised is also about, where does the informal sector live? Where does the vulnerable people live? They live in communities. What is the role of WDCs? So we need to look at how we really invest, and that's where civil society comes in, where civil society would work with communities, state-led accountability mechanisms, WDCs, those structures that currently exist, not ones, to amplify conversations around all of this. I'll leave us quickly because, like you said, it's so short. 5 things.
Yeah, thank you. Yeah.
5 things that I want us to remember from this conversation is that for us to really leverage financing to target vulnerable and poor populations, we must look at the CPF program. There needs to be a deliberate effort at national and federal level make funding is there, 2%, I'll call for it, but make sure there's a protection for equity fund that reaches out to those poor and vulnerable population. 2, we must also advocate for release of resources at both states and national level. States need to play their part. Federal needs to play their part. We need to make sure that there needs to be timely, and what is timely release of resources from the CRF. Then also we need to strengthen community awareness. We need to let people know about the benefits, the value, and of pooled resources or community health insurance or the insurance mechanisms that exist. Then of course we also need to see how we tackle inequality directly. We need to look at how do we expand vulnerable population. Then finally, I would say the use of evidence and data. Evidence, cross-border collaboration, or sector collaboration amongst all parties, whether it's the private sector, whether it's private sector insurance, public sector insurance mechanisms, whatever it is, they just need collaboration and the use of evidence. Thank you very much. Over.
That's great. Dr. Ufoma, male, not female. Thank you very much. That's quite passionate. It's a passionate delivery of your insights concerning how, the political economy of financing healthcare coverage. There are a few things which you have said, but because I would not want to preempt the other speakers, I will wait until they have spoken before I give my insights and what I know about the Basic Healthcare Provision Fund and other arrangements to ensure that there is equity in healthcare access, particularly for the vulnerable and the poorest of the poor in the country. I will discuss that as I continue to moderate this session. But so that we don't waste our time further, I would like to call at this moment on the next speaker in this panel discussion. So please, Moses, I know Moses is a male, Ayebiowu, National Coordinator of Health Insurance. You have the floor for the next 5 minutes, please.
Thank you,
Moses, please.
Thank you all for your great and noble contribution. For the love of country, we have come together to discuss on this most critical part of our national life. Health is the without health care, you can't do banking, you can't do manufacturing, you can't do farming, you can't do nothing. So that is why healthcare must be number one. And besides that, it is also a critical element when it comes to wealth. That's why they say health is wealth. So when it comes to the issue of universal coverage, it is a passionate issue. It is very, very passionate for us to look deeply into those things that are holding us back as a nation. Vis-a-vis the work going on globally, from the world developed countries to developing countries and to the underdeveloped. The work that has been done in developed countries has shown to us that UHC is possible. Because sometimes when you advocate for it, or when we are talking about it, it's not possible. But we know that it is possible. And that is the essence, the critical essence of this forum and this event. Number one recommendation for solution that we are given from the Institute for Health Insurance and Management of Nigeria is education. Education. We must move from the realm of advocacy to education, because all the various regulatory supporting organizations, stakeholders must be educated in the act of UHC. And without that, we cannot move forward. We have seen the literacy level when it comes to UHC very, very low. So we must address that from the grassroots level. from the local government to the state government to the federal government. So it is very, very important. So if we can do that, everybody is aware of this concept of UHC. It will make people, and automatically keen into whatever it offers. But because we have been unable to educate people, even on health insurance, many people don't know what the meaning of health insurance is. They don't know. They find out that, when you ask, even from those that are practicing it, the hospitals, you question them, you talk to them about health insurance, they say, what? What are you saying? Even our senators, our lawmakers, how much of health insurance do they know? So even some of them don't carry health insurance card, they don't have it. So what they are going to advocate upon or make laws upon about in the National Assembly, they don't have such, they don't participate. So it is education that will solve that problem. That's number one. So that's from the lawmakers at the federal level to the lawmakers at the state and those legislative arms at the local government. Everybody, it must be continuous education on the art of UHC. Because
you have 2 minutes more, please. You have 2 minutes more.
Yes, yes. So let me go to the second most important aspect. The second most important aspect is funding. After education, we go to funding. We advocated for what we call crowdfunding. Crowdfunding. Crowdfunding is a system where this UHC is funded from the activities of various stakeholders at the federal level, at the state level, at the local government level. We know that the policies must address that. If the policy addresses that, then the money, the funds will be made available. Number one, through telecom tax. We can do telecom tax in order to get money to fund UHC. We can do aviation tax. When you buy a ticket, you pay some money to UHC. We can do tobacco tax. When you buy tobacco, you smoke cigarette, you pay to UHC. We can these exotic drinks. SSB, we have some SSB, all those exotic drinks that cost normal 350,000. If you can buy 350,000, how much is your contribution to UHC? So it must be holistic. And to our actors and actress musicians that are earning money, Davido is buying a jet of 350 million, and if there is no coverage of people in his family, there must be a percentage. If you are buying an exotic car, you are buying your Rolls Royce, you pay 50% of it to UHC fund. So that is it. Through taxation. Then the profit tax. We look at profit tax. The area where companies will declare profit of 199 billion, 200 billion, 300 billion without paying anything to healthcare is absurd. It's unacceptable.
Thank you very much,
when
Moses.
we leave that issue of funding, we go to digital infrastructure. We must go to we have a project now that I happen to be a consultant to. It's called Matan FRS project. MAT is what we call Market Traders Association of Nigeria. We have over 40 million people on the digital platform of Matan. And we have signed an MOU with FRS, with joint out in order to see that percentages are going directly to healthcare, to fund, to be an incentive to those traders paying. If you get to the market now, you see multiple taxation, you see people being exploited on daily basis. How much of this is going to healthcare? Nothing. So this money must be realized in such a way that some percentage must go to healthcare as incentive for paying taxes to government. So then after that digital infrastructure is acquired, where everybody is duly identified with unique station, we will be able to do more when it comes to that achieving UHD. Then
thank you very much, Moses.
The area of
Moses, we need to stop now. Just give the last.
Give me 1 minute, please.
Yeah. Round up.
The area of accountability. Of all the basic National Basic Healthcare Fund that is being spent, how much goes directly to healthcare? We notice that some states just collect their funds and they just share it. So they are not properly accounted for. So that is one of the bases of the process. There should be processes that are transparent, that are covered, can be monitored, can be managed, can be measured. It's not just advocating for more funding to healthcare. What about the accountability on the part of government and the stakeholders? It must be done. Then
finally, 3 times.
Cooperation. Thank you very much. God bless.
Thank you very much, Moses. You spent almost twice the time, but then it's unfortunate we don't have it. These are very insightful contributions that we have received from Moses, particularly talking about the digital infrastructure for Matan, and then talking about he talked about crowdfunding. He talks about pro-health taxes, and pro-health taxes are limitless that we can actually explore to ensure that we use to finance healthcare for the informal sector. Because we don't have much time, I will just go straight, call on the next speaker on this panel session, and that is Dr. Dorothy Nnamani, MD CEO, Novo Health Africa. Please, you have 5 minutes, ma'am. I know that Dr. Dorothy is a female, so do you have that? Is she there? Is she in the house?
Hi,
Dr. Dorothy.
I'm here. And
okay, please, you got 5 minutes to share your insights. Yeah.
Okay. Good afternoon or good evening, everyone. I am going to make sure that I spend only 5 minutes. Well, yes. Thank you all for the insightful discussion so far. And I'll be speaking from a point of somebody who has lived and this informal sector healthcare financing. I say this because I have designed the informal sector. We did that through the Union of Road Transport. In that program, we also partnered with the government agency, which was the Federal Road Safety. So I'm going to just break up my discussion into 3 things. And I feel that's the way to look at the informal sector participation. I don't necessarily agree that the informal sector cannot pay money, because if you look at their life, they actually pay for what. So I think first we need to look at the packaging. We need to look at the more. What are the plan in this healthcare financing to them? If you bring on that day, I can tell you that they will participate. They are willing to pay. They are way that they say is normal to them, normal in their everyday life. So I see that in most cases when we prepare a program for the informal sector, tend to not bring them into the discussion, not finding out how they really want to be participants in this program. Somebody earlier mentioned it. So I think that is key. Also, we also look at government. But what about I think there was also a person who spoke on that, how people didn't want to participate in the government program. So for them, there is their own government, which is outside our own government. That's the government that everybody knows. So there's an informal, and this is the association that they are in, the hierarchy of the groups and everybody that are in, that push them through those those associations, groups, and all of that. I can tell you that in the formal sector, they pay more attention to what people, the authorities or the executive have to say than what the government that we know, government, that's formal government. So the informal government is very important to them. The third one will be also, somebody mentioned WhatsApp, right? That we all pay and we don't know. Exactly. That's also another way to look at it. And this doesn't really have to be about the amount that they pay, but how are you packaging it? How are you bringing insurance to them direct, knowing that they have religious, cultural factors that may deter them into participating in this health insurance? So we need to look at a way of bundling health insurance, not just as a plain or one product, but something that is bundled with another need for them. And they can see how that reflects. Because without health, I mean, there's really nothing anybody can do. So they begin to value their health. And we also talked about advocacy. Advocacy on what level? Every time we talk about advocacy, I hear this in many places, advocacy. What level are we actually, who are we preaching to? Preaching to, for instance, somebody wants to provide health insurance for a community, and the person goes to the local government and starts talking to the people from the office of the local government chairman. How do you think that will flow? It can't, from what I know and from the experiences, is hardly sustainable. So we must look at the level of advocacy. How are we telling these people? These are people who spend money buying other things. They're not necessarily poor. And I'm not talking about the vulnerable here. Yes, the vulnerable cuts across, the society, whether you're in the formal or informal sector. But the vulnerable is a different kettle of fish. These are people who the government must use whatever means that is available to them to ensure that they participate. They consider their ability to pay, and then some they can subsidize, and some they might just pay outright or make, have a very, I say, very nice and resounding social welfare system that caters also for health. So I'm not really just looking at the vulnerable. I'm looking at the informal sector. I'm looking at the everyday person who is in the formal sector, who goes out, who purchases a call card, who purchases food in the market, who takes transport. Yes, we all complain that it can't, but people still go out there to fend for themselves. And there has to be a time where they recognize that health is also part of their rest. So they must their health and recognize that the health care, they need to pay for it. Now, there's a part of it that there is something that falls on the part of the government. You're asking people to pay for their health, whether through insurance or whatever it is. Where are the facilities? How are the facilities being managed? Do we have enough facilities, whether privately run or government? Have we unbundled the healthcare journey or the access journey in such a way that it is less complex, it's less complicated, that people can actually find their way, just like they will go to Odibo market or go anywhere and then purchase exactly what they want. Have we done something about that? Then after, so government has to look into that proper regulation, streamlining all the people that all the actors in the healthcare system. They must be streamlined so that people, anybody who needs healthcare, so that should not also be an obstacle. Because if you preach and advocate and everything, and you talk about health, and then when it gets to the time of access, there's all that complication. There's go and buy your cotton wool. There's go and buy your syringe. Buy this. Go here. Come here. What happens? The person will rather turn around and then go to the next pastor or babalawo or something, and then go and, who they can access seamlessly. So that is the part that government has to play. They must make sure that there's seamless access to healthcare. Just health insurance doesn't really give that. I have purchased a health insurance does not give me access, because health access is also at different levels when bundled out. You have access, physical access, you have financial access, you have what do you call it, like a professional access. If I go to a hospital, I have hospital, the hospital is there and it's only filled with what do you call it, Eliza nurse, that's the quack nurses and all of that. Has the person actually had access to healthcare? So these are the things that we at this, I think I just made 4 points where experientially I have, these are the things that I found out in trying to create value through health financing for the informal sector. The poverty is really not their problem. Like I said, they can pay. They are willing to pay when approached the right way. And but the other supporting structures, whether human or capital, whatever it is, infrastructure has to be in place, because these people have trust issues in the community. A very little thing, if you tell them to go to point A and they get there and they don't see what you're telling them, I'm telling you that program is dead. So we have to ensure that whatever it is that you tell them is what they're going to get. So thank you, everyone. That's my $1 contribution.
Doug, that's more than $1. It's great. From there, we see that you were talking about, that these people that we're talking about have a willingness to pay, and in fact, they have the capacity to pay, but is the payment modality fashioned in a way that is acceptable to them? If it
the
is,
program design.
So that's quite important. And then, of course, ensuring that after they have paid, at the point of service delivery, they are able to get seamless quality service. That is
exactly. Just one more note. For instance, look at the money points and OPAs of this world. The banks were there. These people were not putting their monies in the bank. But when the OPAs and the money points came, what happened? You have millions. Exactly, because it was structured in the way they want. Exactly. They all have back accounts. They all have back accounts. So
thank you very much.
So we need to formulate a program that suits all of
interventions in such a manner that will be acceptable to the people. Thank you very much for those insights that you have shared with us. I would like to invite right now, straight away, please take your notes and then make your comments. Richard Akpoveta, you will have an opportunity to talk. Ibrahim Omar, you'll have an opportunity to talk. Please, let's just run through this, and then we have just about 30 minutes to round up this, and I think we've really been educated, and we're receiving lots of insights. And I'm sure after this, we'll be able to develop and design interventions that will expand access to healthcare for the informal sector. So let me bring on board now Alhaji Safana, the Katsina State Contributory Health Commission, Executive Secretary. Please come on board, Alhaji Safana. Are you there? Safana, are you there? Are you in the house? Okay. If Muhammad Safana is not on in the house, can we go straight to?
Apologies, Dr. Ogene is on the meeting with the.
I'm here. Oyene is here.
Okay, so please let's go straight. Let's listen to Dr. Oyene. I'm told that Dr. Safana has a meeting with the executive governor, and so he's not able to join this meeting. So please, Dr. Abiodun Oyene, my brother, the Director General of the State Contributory Health Commission, Ondo State, please, you have the floor for 5 minutes to share your insights and to share your experience with us on political economy and how it can, it affects financing health coverage for the informal sector. You have the floor. Thank you.
Thank you so much. Let me use this opportunity to thank the organizers of this webinar. It's been very robust, the presenters and the panelists. Because of want of time, I will go straight to my point. A lot has been said today, but just to add a few things, what other things are also peculiar in dear Sunshine State. Talking about political economy, I think one area that need to be closed is trust deficit. And I think one of the presenters mentioned the issue of service delivery. Since when NHIS started, if services are delivered well, that's the best way to attract people in the informal sector. Quite a number of states now have their state agencies, and most of their formal sector schemes are doing very well. So I think the focus more with states, and I think major stakeholders should be in terms of service delivery. We talk about telecoms. If you don't have good service delivery, you are not going to go back to your service provider. So if service is being delivered, and I think government need to do more in terms of infrastructure, in terms of retention of health workers, in terms of attracting the best hands, and also giving enabling environment for private providers to also thrive, so that if service is delivered, then people from even words of mouth can attract more people to be having that willingness to pay for health insurance. Because if we look at the cluster of people within the informal sector, we have a large number of people that are actually gainfully employed and they are willing to pay and they can afford to pay. So if we target them, but the only thing that can keep them to continue to renew their insurance premium is if they get value for the money that they are contributing. Second important point is that I think Dr. Ogini also mentioned the issue of contribution and collection. So it's not so much as in the affordability of those resources, but how do we collect the premium from the informal sector since they are not organized? So it's either we go through the associations, it's either we use financial institution to be able to be the collection platform for them. For in Ondo State also, we're also looking at developing a USSD platform where people in the comfort of their zone can actually pay their premium on their phone. We're also targeting those in the diaspora so that people can actually pay for family and friends back home, because if you convert some of this premium into dollars or pounds, it's just a meager amount of money that people can pay for. The aspect of advocacy and education is also very key, because if political leaders are going to advocate and encourage people in terms of this policy directive, people need to have health insurance now that is mandatory. They need to lead by example. And we can see that demonstrated in the state, in some states like Anambra, Imo, where we also have adoption model, where we have political leaders adopting for those that cannot afford to pay, or subsidizing for those that we want to encourage to pay, and leaving those that can actually afford to pay directly by themselves. The current budget in Ondo State now has moved from around 5% to 7%. So I think that's encouraging to ensure that policies are put in place to ensure that service is delivered, because we cannot do anything to increase coverage if we don't deliver the service. You can bring the people on board, and if service is not delivered, then they are most likely going to drop out. You don't want that kind of a thing. Another thing that Ondo State has done is also to put measures in place to attract and retain health workers. Human resource is very, very key in health insurance. Now there's a policy to ensure that the entry point is level 13, and also that the salary should be at par with what they pay in other contiguous states and also the federal government. Sometime in February, by the grace of God, we'll be hosting the Dawn Commission, having a kind of a regional conversation about regional integration. So when you have that, people that have health insurance within the informal space can also have service delivered to them if they have to visit contiguous states, then I think that will also be a bit of an encouragement. You see people going into so many activities that we only need to encourage them. I think the head-seeking behavior of Nigerians also, we need to work on that. People don't put premium on their health. And I think a lot of states also need to let people know that the conversation has moved from free health to health insurance. Because if you are singing the discordant tunes, on one hand, you are talking about free healthcare. On the other side, you're telling people that they should buy health insurance. Then people get confused. Then people would rather be willing for government to give them free health insurance coverage. So I think most government now are shying away from making health a political conversation, making sure that health is a right of the people and they need to have health insurance cover. Those that can afford it should pay for it, and those that cannot afford it through either the vulnerable group fund or the equity scheme that most state governments are currently implementing can cater for those that are actually on the lower rung of the economic status for government to take care of them.
Thank you very much, Dr. Enai, for staying on point. You already told us about three sources of one source which you have included is the equity scheme. I mean, the equity contribution that's supposed to come from the states to take care of the vulnerable in the group, in the population, in the states, and in the nation. You talked about the Vulnerable Group Fund, which is also, creation of the National Health Insurance Authority Act 2022. And then we have the Basic Care Provision Fund, which is a creation of the National Health Act 2012. All of these are, policies that have created an environment for funds to be available for the, vulnerable proportion or the vulnerable sector of the informal sector. Now, you also talked about ensuring that there is more investment in human resource for health so that you can engage, they can be employed, and then they can be retained. Because when all is said and done, if you have mobilized all the funds, you have from the demand side brought people to the, supply side. Once they get there and they are not encouraged by what is there, then they will never come back on the scheme. Thank you very much for those insights that you have shared with us and the experience. We will go now. Because we have just 25 minutes more, we will take this presentation before we now take all the questions. So please just put down all the questions, and some of you can put the questions in the chat box. We are reading the, the comments in the chat boxes, so you can put your questions there, and then you can put your comments as well. But beyond that, we want everyone that has been on this call to send their email addresses. We are going to share all of the slides, the presentation slides. We're going to share all of them with those who have been on this call. So please ensure that you put your email address on the chat box so that you can be sure to get our, the slides that were presented. So keep your questions while we go to the next presentation. This presentation is on health coverage for the poor and vulnerable constitutionally and legal matters arising. Constitutional and legal matters arising. No other person than Professor Odeme Victor, Professor of International Law and Diplomacy and member of the Advisory Board of Africa Economic Forum, Center for Sovereign Debt Management, Abuja. Please, Professor Odeme Victor, you have the floor. Professor Victor Odeme.
Yes,
yes. Do we have him on the call? So please, you have the floor, sir.
Okay.
You'll take us through the presentation in 10 minutes, and then we'll take reflections, and then we'll do our wrap-ups. Thank you very much, Prof.
Okay, good evening, everyone. I hope you can hear me.
Yes, we can.
Okay, so I noticed there's a mix-up in the topic that was given. So I'm going to present the topic that I was given earlier, not the one on the agenda.
Okay.
And what I'm presenting is a financing informal sector health coverage in Sub-Saharan Africa, lessons from Nigeria. What I will do is to spend a little time to create a picture of what a health financing is at this point in Nigeria. Then I'll play with some ideas as to financing it. Now, the first thing as a background, as housekeeping, is providing reliable, sustainable, and affordable healthcare services has proved a long-standing challenge for many developing countries, the bulk of which are in Africa. This is because modern healthcare facilities and associated delivery networks are complex and require significant capital investment, which impacts the physical space for most African governments. The fallout from inadequate healthcare facilities / infrastructure are numerous. They include complicated health issues, many of which stem from access to healthcare encapsulated in the late entry into the regulated health system, wrong or late diagnosis, inadequate drug supply that have placed tremendous burden on families, caregivers, and the national health system. Unfortunately, in recent years, African governments have keyed into the Western governance protocol, regardless of development's divide, that sort of rent out much of its responsibilities in the name of privatization, or more specifically put, private partnership, public-private partnership, and the case to allow public institutions stick to their respective areas of competence.
The intention has been, perhaps, to offer governments more time to pay attention to governance and national security, given the heightened security challenges obvious in recent times. This phenomenon has grown monstrously to provide government the opportunity to even give up their basic responsibilities to citizens, such as water schemes, education, healthcare, which are the foundational issues in 21st century security model called human security. Consequently, African governments are increasingly looking at public-private partnership, which provide an opportunity for a near-perfect blend of skills and resources of the private sector and the public sector, with private sector delivering capital and technical know-how, and governments providing laws, regulations, guarantees to improve access to healthcare services. However, in the implementation of the private sector component of the health insurance scheme, governments have failed to take cognizance that health insurance is more of an investment in the insurance business more than it is medical practice, in which case adequate care has not been taken to engage appropriate persons to man the affairs of national health authorities as business entities rather than as social services. Now, this paper is divided into four. One is the introduction, which I've taken, then the other is financing informal sector coverage, lessons from Nigeria, and then the conclusion. And the paper consists that what needs to be changed is the perception of health insurance as social service instead of special insurance investment business scheme, for which a health economist or health insurance expert is needed for its sustainable management. Now, let's look at financing informal sector health coverage specifically. We will realize that sometime in September 2000, under the Millennium Declaration designed to improve social and economic conditions in the world's poorest cities by 2015, heads of state of African countries in April 2001 pledged to set a target for allocating at least 15% of their annual budgets to improve the health sector and urge donor countries to fulfill their promise of 0.7% of their gross national product. That's what the Abuja Declaration said. But then many countries that are donors are looking at gross national income. So it's important to note that the benchmarking of 0.7% of GNP stemmed from the fact that 5 of the 22 donors at that time were given at least 0.7% of their gross national incomes. However, not much has been achieved regarding the level of real per capita development spending from domestic resources on health, as many African countries continue on the downward trajectory. In countries like Burundi, Benin, the Democratic Republic of Congo, and Cameroon, per capita public health spending has been as low as $10 during the past decades. This includes Uganda, Nigeria, and Guinea. Specifically, Nigeria has gone from $10.8 in 2020 to $8.5 in 2022. Both options are way below WHO recommended targets of $86 per capita. Indeed, most African Union countries are yet to be on track to achieve the health MDGs. And COVID-19 became an eye-opener for countries of the Sub-Saharan Africa to the critical need for prioritized investment in healthcare. The idea of the prioritization of healthcare investment is to develop a robust and resilient healthcare system capable of withstanding healthcare emergencies such as COVID-19 and other infectious diseases. Now, it's important that many writers have agreed to a short list of issues bedeviling financing of informal sector health coverage in Sub-Saharan Africa. The identified issues include, but not limited to, limited finances. The issue in the informal sector, regarding limited financial capacity, the issue is that informal sector workers are often have irregular or low incomes, which makes it difficult for them to afford healthcare premiums or out-of-pocket medical expenses. Now, the other is the informal nature of employment. Many employees in the formal sector do not have formal contracts and do not have adequate tax records, which become a challenge when it comes to identifying and tracking informal sector workers, a situation that hinders the implementation of targeted health insurance schemes. The other is geographical challenges, which is to say that the informal sector workers in Sub-Saharan Africa occupy vast, vastness of the country, and often are located in remote, unmapped work locations, which makes it impossible to insurance programs that can reach them.
We have 3 minutes. We have 3 minutes to go, sir.
Okay, so the other is limited government.
Please, let's
administrative challenges and poverty, and ultimately the debt burden of African countries. So let me go to what we think are the solutions. The first is an enhanced budget allocation to the healthcare. However we look at it, healthcare remains a cardinal responsibility of the state. So enhanced budgetary allocation to the healthcare sector is a signal to the private sector, government's commitment to the sector, which serves as a catalyst to encourage the private sector to engage and show additional commitment to the health sector and development of a given state. Now, it must be noted that South Africa is keeping to the Abuja Declaration. Now, the other is external funding.
Yes, you are on mute.
External funding remains a cardinal pillar for funding of the informal health sector in Africa. And we need to encourage the donors to stick to their quota of funding healthcare in Africa. Now, the other is leveraging the private sector expertise and financial support through what we regard as primary healthcare bond, which is a private sector initiative that leverages on expertise and financial support to strengthen health financing. Now, the other is private sector engagement at the point of policy making. Then treating health insurance as an investment, reducing medical tourism, developing adequate partnership with the social sector, workforce deployment, and we have to address weak institutions and policy somersaults, which is a function of African governance that is characterized by weak institutions and strong men. Now, the other is also to pay a greater attention to management of our sovereign debt, which is a burden onto us. Sovereign debt is now a new form of slavery. And lessons from Nigeria is that through the National Health Insurance Authority Act 2022, a whole lot of effort has been made to bring in the informal sector into the health insurance, which serves as an impetus for them to gain access to the system. My conclusion is that health insurance is insurance and not medical practice. Therefore, a health economist, insurance executive, or even an investment banker would do a better job of mobilizing funds for the financing of informal sector health coverage in Sub-Saharan Africa, more than a medical doctor would do in that position. Thank you.
Thank you very much, Prof. Thank you very much, Prof. We wish we had much more time to be able to, take all of the information you're passing on to us and all the education. But unfortunately, time is not our friend right now. And at this moment, what we have next, which we want to do, is yes, take the questions and the answers. But before then, I would like to call on, Dr. Hope Uweja, our Chief Engagement Officer. It's unfortunate that we don't have much time now. So if you are not able to ask your questions before this session ends, we will just please put them on the chat box, and then we're going to address them. With your email addresses, we will also, make sure that we reach out to you. Dr. Hope Uweja, please, you have the floor.
Yeah, thanks. I'm just coming in to recognize the representative from the Embassy of Togo, which we at Togo is already collaborating with us for our upcoming event in Kigali. So we wanted to recognize the expert technician, that is present with us here during this presentation. I may not be able to recognize all of them, but I want to use this opportunity to thank everyone who made today great.
Thank you, sir.
From development partners, from the government, especially these agencies at the subnational level. We can't thank you people enough. We also want to thank our partners and would-be partners and all distinguished ladies and gentlemen, especially again from the Office of the Special Advisor on Health. We want to thank you all, and we appreciate you, and I'm sure we would look forward to seeing you in Kigali in April as we host the African Health Financing Forum with the master classes and the side events, which we believe will introduce and take Africa to a new level of health financing and work towards universal health coverage. So I thank you. And I also want to thank our moderator and senior fellow on health financing, Dr. Guinea, who himself coordinated the various panel sections. We can't thank you enough. And of course, I don't want to end without thanking the resource persons and the panelists that were present, especially Professor Udeme, who has just newly been promoted to the rank of Professor of International Law. I want to congratulate him and thank him for being present with us here. Professor Deme is now going to serve as our Executive Director for the EF Center for Sovereign Debt Management in Africa. So we want to thank him and to appreciate his contributions. May God bless you all. Thanks.
Thank you very much. Ladies and gentlemen, like we have said, we have to close this meeting. It is my pleasure having, had the closing remarks from the Chief Engagement Officer. I would just like to reiterate that the activities of the Africa Economic Forum continues. That is an event that is coming up in Kigali, like he had said. We will send the flyers as they come out to all the participants, and we'll do well to share with all our groups, and then to ensure that we continue this conversation and we continue the actions towards developing innovations to ensure that we achieve universal health coverage. Having said that, I want to thank everyone for this meeting. Thank you very much for the participation. Please put your questions in the chat box, and then we will address it, online. Thank you very much. God bless. And I observe that there are still a few people that are left here. Maybe I should use this opportunity also to, somebody said, is there an organized or yeah, so thank you for all of these questions. We are actually gathering them all. We are going to work on all of these questions and get back to those people who have raised the question. I wish all of us a very Merry Christmas and a very prosperous New Year.